Hello, welcome. So this talk maybe demonstrates two things. First off, if you're supposed to find speakers for grand rounds and you wait too long, you wind up having to do it yourself. That's number one. So that's always a hazard. And number two, well, we'll talk about how sometimes things that maybe seem sort of painful when you're a resident can actually turn out okay in the long run. I have a couple of disclosures. I have no financial interest in this talk. Not a lot of other interest either, maybe. No, sorry. The animals were probably harmed in the making of this talk. I have to disclose that. So I have to go back to 1988 when I was a freshly minted intern at Washington University. I happened to arrive the same day as Joel Cooper, who had come from Toronto and is probably the world's preeminent lung transplanter, came to Washington University with a brink truck full of money to set up a lung transplant program. And for a while, they had the largest transplant program in the country there. Coming across the autopsy table sort of shortly after I got there was the first person that he transplanted after he got there, who was, quote, doing well in rehab when she suddenly exsanguinated in the middle of physical therapy. At that time, they were actually, when they did double lung transplants, and I think she was transplanted for pulmonary hypertension, they actually did only one anastomosis above the carina. So the carina was intact, and they actually did a single anastomosis. And it turns out that they noticed that there was some breakdown there, but their clinical notes kept saying it was granulating closed, it was getting better, it was looking better, until apparently it fistulized directly into the pulmonary artery, and one day she just bled out rather massively. She also had cytomegalovirus, pneumonia, and some rejection and some other things. So how well she was actually doing, is it may be a matter of some speculation. Dr. Cooper was literally standing over my shoulder the entire time I did this autopsy. If you have surgeons doing that, it's kind of uncomfortable. And I years later, I reminded him of that, and I said that I actually thought for a while that he blamed me for killing her. I had to assure her that she was dead when she came to the autopsy area. And I got to go present this case to a rather hostile group of M&M people who just didn't believe that could have happened, that there could have been that finding. Ultimately, these guys gave up on this double bronchial anastomosis, which most thoracic surgeons said would never work, and actually now do a double bronchial anastomosis with each lung. They essentially do 2 single lung transplants. So that was my introduction to the world of lung transplants, and I got sort of interested in that. It really started in the 1980s with heart lung transplants, and then evolved into isolated single lung transplants. And if you look at the numbers worldwide, in 2007 there were 2,700 lung transplants, which I think is pretty small potatoes compared to kidney or other organs still. So it still sort of lags. It's newer than many of the other organs still in relative terms, and there's still fewer of them going on. There was a really nice review that came out of Washington University of their first 1,000 adult lung transplants in a single center. You can see this spanned the time from 1988 through 2009. And the diseases that people are transplanted for, you would expect emphysema is the most common, with CF number 2, and then a variety of other things, pulmonary vascular diseases, which I think, this is now lower now. We seem to have taken care of many of the patients, and it's only the newer folks coming along. IPF has crept up over the years, and then a variety of other rather unusual things. It's still striking what their time on the waiting list is. 510 days for the average lung transplant person over that period. So obviously your chances of getting a lung transplant if you have any kind of really acute problem, in particular with the older organ allocation system, was virtually nil. You got in line behind somebody and waited. So if you could survive for 510 days, you could get a lung transplant. But people with acute pulmonary fibrosis or diffuse alveolar damage who maybe would benefit from a transplant, we're never going to get that. And you'll notice some things at the bottom here in terms of primary graft dysfunction, which is really ischemia reperfusion injury, still has a very significant rate of occurrence in these patients. And there's a really busy slide, but a couple of interesting things that have happened over the time from the beginning of this through their last 200 cases. You'll see that their shift in diseases that are transplanted, with fewer emphysema patients and more patients with things like IPF. And again, that may reflect the organ allocation system. If you're sicker and you have IPF, now you can actually get ahead of some of the people who have chronic pulmonary disease who may actually survive longer and get on the list earlier. And also, there's been some striking improvements in the initial hospital mortality and in the rate of PTLD, which was almost 10% in that first cohort of 200 transplants, but is now down to 3%. So a really significant decrease, and reflects, I think, better immunosuppression and sort of better overall management of those patients. And so you'll notice that there's been a significant decrease in that sort of initial hospital mortality. And when you look at the overall survival, it's actually improved a little bit. This line here is their first 200 patient cohort, and you notice it comes down relatively quickly here because that's that initial hospital mortality and some of the initial problems. And then I would argue that there hasn't really been a lot of change here, minimal improvements over time. This one is their last cohort, but these lines cluster pretty close together, probably with much of that difference really being due to the initial thing, and there's still a substantial follow-up. So these patients, are still not living on average for 10 years. Their median survival, their 50% survival line is somewhere around 6 or 7 years, something like that. So not something that you want to have, I think, unless you're relatively in bad shape. And so the rejection scoring for this really got started with this first paper that came out in 1990, and they identified really the cardinal lesions, that there's perivascular inflammation is really the cardinal manifestation of acute rejection. There was also small airway inflammation or lymphocytic bronchiolitis that occurs in these patients. And then, there was note of chronic rejection, various ways of scoring that, active versus inactive, whether it had a continuing inflammation, whether it was a total destruction of an airway or partial. And then chronic vascular thickening that no one ever mentions is always at the bottom of all of these lists. And so here's a small pulmonary vessel, and it's got a little cuff of maybe 1 or 2 lymphocytes around it, and that's the sort of lesion of an A1 or the mildest form of acute cellular rejection. If you go to something that's an A2, it's something that you can see much more obviously at low power. It's still mainly confined to the adventitia of the vessels. And interestingly, much of the inflammation that goes on in these cases is still sort of perivascular, but as you go up in grade from 1 to 2 to 3, here's an example of 3. Now it's got inflammation that's not only around this vessel, but it's beginning to creep into the adjacent lung, and then that starts to cause really lung injury and some other things. And in addition, you'll notice here there's much more endotheliolitis. There's actually inflammation and destruction of the endothelium of those vessels. There are some eosinophils. These cells are more activated looking. And when you get to grade 4, you really have diffuse inflammation and then graft injury in the form of damage to structures that are in there. So we virtually never see this grade 4 thing. The other target of that has always been the airways. And so the airway epithelium can be targeted. You can see here's an airway with a muscle and some inflammation in its wall, sort of dissecting through there. The inflammation has been largely denuded off, or the epithelium's been largely denuded off. And those are kind of the cardinal manifestations of acute rejection. No one has ever, the airway inflammation, of course, has a lot of other causes, from infection to airway obstruction to a bunch of other things. So that's never been as easily nailed down. The A grades are still kind of what primarily drives their treatment, but we'll come back to what this bronchial epithelium injury means in a bit here. So I was fortunate enough to be a part of the revision of that original 1990 working formulation in 1995 and 6. We simplified that a little bit. So basically, again, you had these 4 grades of acute rejection and then airway inflammation, that lymphocytic bronchiolitis. And the major point was some simplification of the airway rejection, simply as to whether it was active or inactive. Trying to tell whether it was the airway was completely occluded or partially occluded was really very difficult in biopsies. And the initial thing had a bunch of subletters for inflammation and edema, and I don't know. The diagnosis sort of ran on forever. So we thought this was a pretty simple, we kind of simplified that schema. And I think, so just to look at that, I did a lot of work with a pulmonologist by the name of Murali Shakanala. We sat and looked at biopsies like twice a week for a big chunk of the morning for a couple of years. I love this guy. He had 2 things that were really annoying about him. He was a Duke graduate and had to hear about Duke basketball constantly. And he was from New York, and so we were looking at these when the Twins were always playing the damn Yankees in baseball. Like, what could be worse? You know, have to come in on a Monday morning and say, yeah, I know, we lost again, thanks. So other than that, I thought he was other than those 2 drawbacks, he was a great guy. So we actually said, you know, like, how well does this system work? And so interestingly, you know, at the first thing that whenever you start talking about reading transplant biopsies, people say, oh, well, you got to have them. They all have to be read by one guy, and it has to be an expert, because normal people can't do this. You have to be some kind of super trained, whatever. Well, at WashU at this time, we still had a very, those transplant biopsies went to a variety of people. In fact, so we took a look at this cohort of 204 people. The biopsies were actually read by 18 different pathologists. You know, some of us had a larger chunk of those, but we had a variety of people who looked at these cases, and then we said, you know what, how are we going to do? You know, if we go back and review them, does anybody know what they're doing? How do we score this? So again, we looked at a huge number of cases. There were almost 1,000 cases in there. These were either surveillance bronchoscopies. Some of these were clinically driven in terms of the patients having graft dysfunction. And again, here's the distribution of pathologists. One of these bars is me, I think, and then we had other, which is the other 11 people who looked at these cases and signed them out. So we had a large number of people who read these biopsies. And it turns out that if you look at our review reading and the initial reading, the distribution of the grades of rejection and stuff looks pretty much the same. That doesn't really tell you all that much, and not so much for the airway inflammation. That's always been a little harder for people to get a grip on, I think, and we'll come back to that in a minute. Of course, that doesn't really, you know, we could have had every one of these could have moved around, and it wouldn't have meant that this thing was reliable at all, because all 800 or whatever migrated to some other location. So if you look at this sort of plot, you can see that for the most part, we had good agreement looking by kappa score. The overall concordance rate was 76%, and the kappa was 65, which is actually in the, quote, very good range, and I think exceeds what you see in many other pathology examination studies when you look at correlations. It turns out it was very similar to studies that have been published for a review of heart biopsies for rejection, and actually, sorry Sean, much better than what people can do with liver, and it does validate my point that liver biopsies are much harder to read with a great agreement. But you see that we had there were most of the cases that were A0 stayed as A0, and a few went to A1. Now the interesting part is really they don't treat anybody typically with A1 or A0, and they start treating people at A2 in this scheme. So there were only 12 cases really that migrated out of that, and we'll look at that in a minute. The airway inflammation scoring was much more, had much poorer overall concordance of only 56%, and the kappa was only 0.26 for that. Now, if you basically then dichotomize this data to say, well, you know, if we just say less than or equal to 1 and greater than or equal to 2, because those are really the clinical bins that they go in, you get about a 90% concordance rate with a kappa of 0.67, which is slightly better. And the same thing happens for the airway inflammation. The agreement does improve some. So our take on that was that variability in this cases were really very good, and it seems as though people can look at these biopsies, can score them reliably, and generate good data for the clinicians to use to treat these cases. And in fact, when I looked at my own intra-reader variability, my kappa was 67, which I guess means my mental status is probably okay. I don't know what else you can draw from that, but it's interesting that it's virtually exactly the same as it was to look at others. And I think some of that variability also reflects when you sit down and you look at a group of cases, it's different than getting that one case in the afternoon when you have clinical information maybe that alters your diagnosis or whatever. And I think there's always some kind of inherent bias whenever you start kind of secondarily reviewing something when you know it's a study and it's not the clinical treatment of the patient. But the A grades seem to have very good reliability. The B grades had only fair reliability, and we said, you really need to maybe pay attention to these in some future revisions of that scoring system, because obviously we're not doing it really as well as we maybe could. The other question is, do these patients really need all these? How many biopsies do these patients need? If you look, some of these people are in, I think they get biopsied before they leave the hospital. They get a biopsy at 2, 4 months, 6 months, a year, all sort of continuing, even if they're well, with the idea that, with the notion that that they have a significant amount of occult rejection that's going on, and that if you wait until they have symptoms, very very analogous, I think, to heart transplants. If you wait until somebody shows up with heart failure, they're going to have really significant rejection and long-term damage. So again, with my annoying Yankee fan friend, we reviewed another giant group of cases, and it turns out that we took, again, these 240 or 204 patients who had an adequate number of biopsies and looked at really everything they had in the first 5 months, the first 150 days post-transplant. Out of that group, you could see that 67, only 67 of them had no evidence of rejection on any of those first initial biopsies they had. 137 of them had some evidence of rejection, and then sort of went on to take these guys and look at what happens to them in a later period. So what happens to them then out to 400 days on this kind of subset of patients here. So as you see, if you look at months after transplant and what the yield is for these surveillance biopsies, it's sort of highest early on, which kind of makes sense. As the patients are first kind of getting dialed in with immunosuppression and such, they have almost a 50% rate of having at least A1 on one of these biopsies, even though they're asymptomatic. That decreases out to 12 months. And again, if you look, though, and if you say, well, what if you have several normal biopsies, then you must be okay at some point. And if you say, okay, if you look at the cumulative yield and then you say, okay, you were normal, but how much shows up on your second and your third and your fourth and your fifth for the first time? There's still a substantial number of patients who have nothing on early biopsies and then develop, occult rejection on some of these later biopsies. So the continuing follow-up of these patients is really kind of crucial. Again, you can look at the distribution of grades of rejection. And it is sort of what you would expect. Many these patients tend to be more normal early on and have mild to moderate rejections tend to be early. And as you go out farther, you get into mostly the A1s. These are A1, 2, 3. And you can see the patients who develop these sort of occult rejections later on tend to have lower grade ones, but they still have pathology present. And you can look at the cumulative freedom from rejection, in this group of people, out over to 400 days. You're down to less than 50% of patients that stay clear of this. And again, even in the patients who had early rejection versus no early rejection, you don't see really a significant difference in the rate of those things. So it appears that these surveillance biopsies are probably really still important in these patients. And again, they detected rejection in a third or more of cases in the first year. Most of them most of those are A1, but there are some more significant rejections that actually do require probably augmented immunosuppression, and that A1 percentage tends to go up as time passes. And that freedom from rejection in those first 100 days doesn't really protect you for developing something later on. So having now nailed down those A lesions, and in particular with as I said, better immunosuppression, really a good understanding of those. Acute rejection, I think, is a minimal problem in these patients. And if you look at the revision, the 1996, a revision of this 1996 schema, which came out in 2007, in fact, whether a couple of those papers that we did, particularly the one on the reliability, is cited. So if people can't categorize something better, I guess you can give them fewer categories to put it in. So if you simply say there's no airway inflammation, you have high-grade lesions and you have low-grade and high-grade lesions, and X means there aren't enough airways to look at, it's a little easier. And again, the chronic rejection thing, which we're going to talk about in a minute, has undergone some further simplification. So I would like to say, at this point, it looks like we're done, right? Everything's peachy. No. So what's the biggest issue with these patients? And I have to give you another little Joel Cooper vignette, and this one I think is still impressive because I managed to find something in my box of slides. So this time he's standing over me in the frozen section area. He had a case that he was just convinced that this lady who was having respiratory failure about a year and a half after, maybe it was his second or third patient. Now we're in my second year, and I'm in the frozen section area at 7 in the morning because he paged me 6 times in 5 minutes, despite the fact I wasn't the fellow who was on call. I was some stupid second-year resident who just happened to answer his 6 pages. So he was standing over me saying he wanted tissue frozen for electron microscopy or something. I don't know, which I thought he possibly deserved that. Should have said if he wanted some glutaraldehyde for IF or something too, just to further confound that. But at the end, when we looked at this frozen, and it's a relatively obvious diagnosis, he said, no, she can't have chronic rejection. She has to be in the charity fashion show next week. We changed the diagnosis based on that statement. No, we didn't really. So I actually have, this is the actual frozen section slide, the actual last slide, which I put in my pocket at some point because it was just too good to leave. And you can see alveolar tissue here. Here's the muscle from one side of an airway. Here's the muscle from the other side. You can see a couple little pieces of mucosa in here, and here's part of this lumen open, and there's a little bit of a lumen down here. But right in here, this thing is completely full of something. So this is classic obliterative bronchiolitis or bronchiolitis obliterans, depending on, it's kind of like saying Creutzfeldt-Jakob or Jakob-Creutzfeldt, I guess. Depends on which way you like to say that. And you can see absolute obstruction of this thing. And they're not continuous in the airway. They're the sort of discontinuous involvement of airways. But here it is in absolute frozen section clarity. And it's a nice frozen I cut, by the way, particularly with a surgeon getting in my way. So again, you can see a couple little strips of epithelium in here, and then the lumen has just been completely obliterated by this. Here's a similar vessel. You can see the artery over here, so you know that this scar here has got to be an airway. There's a little bit of muscle up around here. So the clinicians describe this lesion as bronchiolitis obliterans syndrome, and they have a clinical definition of it. So you get a lung transplant, you look at their FEV1 at some point after you get over that horrible chest incision and all that stuff, your FEV1 comes up to some level, and then it's going to start to come down, unfortunately, in many of these patients. And when you get to 80%, you're labeled as having bronchiolitis obliterans syndrome. They have made a little pre-BOS thing. I like it. It's like whenever you have a pre-disease thing and then you have an intervention, you have a better outcome than if you treat patients that have the real disease. So that always makes your stats look better. This is really the number one problem in lung transplant, and I'll show you some kind of distressing graphs here. So here we are as freedom from this clinically defined BOS lesion, and you can see somewhere around where's the 50% point here? Somewhere around 3 to 4 years. At least 50% of these patients have have significant airflow obstruction based on this lesion. And this is the graph that I find pretty distressing. If you look at, this is the initial 200 cohort they did from 83 or 88 to 93. And then the rest of these are really superimposed. So nothing has really changed in terms of the onset of that lesion for the last 20 years. And the final graph at the bottom here, the black line here are patients who did not have clinical evidence of preservation injury. The bottom line is our patients that have preservation injury, or this primary graft dysfunction, which is basically ischemic reperfusion injury, which is quite common in these patients. You can see about a third or so had clinically significant preservation injury. They seem to have a propensity to have this later development of this BOS, and so we'll talk about maybe a mechanism of that in just a second. Again, if you look at the rates of preservation injury over time, it's interesting. It's actually spiked up a little bit here. And again, this may actually, what this kind of reflects is the donor shortage. And so they've actually started to use patients who died of cardiac deaths rather than just brain dead patients. So they're basically patients who died and then had organs harvested, which they had not done up until some point here. And also this change in organ allocation, and the fact that there's such a shortage of organs has sort of driven people to use kind of marginal times and whatever. So they still have about a very significant rate of this primary graft dysfunction. And again, that same curve, you can see there's a significant difference in the onset of BOS depending on whether you had that very early lesion or not. It's a very interesting phenomenon. What is reperfusion injury? There is an implantation response that's probably just due to this kind of transient ischemia and edema, but in human transplants, they're still using ischemic times of 12 hours or sometimes more. And so this is really an ischemic injury, and it looks exactly like diffuse alveolar damage or like a bronchiolitis obliterans organizing pneumonia, not BO, but rather BOOP in pulmonary pathology parlance. It's a very common cause of infiltrates, and usually you think, wow, that must be really, the patients must do really terribly. It's diffuse alveolar damage. Since it's a one-time injury and basically it's gone, this is one form of that actually tends to resolve in most patients relatively well, but has maybe some late effects. Obviously, things like infection or severe early rejection could mimic that. I mean, here's a nice example. You just see thickening of the alveolar septae, some pneumocyte hyperplasia and interstitial edema in here. And this one happens to look more like BOOP with this sort of plug of this connective tissue sitting in a distal terminal airway. And again, this just reflects epithelial and vascular injury from this ischemic lesion. And you see, again, edema and thickening of the adjacent alveolar septae. And that usually resolves, as I said. Now, here's a nice example of another lesion of this obliterative bronchiolitis. This one, in the older parlance, would have been labeled as active because it still has a lot of inflammation associated with it. You can clearly make out an airway with a lumen that's been completely full here, but you see a lot of ongoing inflammation that, you wonder if that's involved in the lesion or not. At many points when we see these, you see really a scar, and you can maybe make out a tiny amount of smooth muscle here, but that airway is really, at this point, almost completely gone. And if you look at that a couple months later, all you're going to find is really an unpaired artery sitting there. So it's actually very easy sometimes to overlook that lesion. You look at the lung, it looks relatively normal, and you say to yourself, that's interesting. Why is this patient, dying of respiratory failure? Oh, they don't actually have any airways. Sometimes it's hard to see what's not there anymore. So you have to, be really cognizant of that. Of course, there's, hyperexpansion and air trapping probably, adjacent to this. You see these greatly expanded alveolar spaces. And again, I want to emphasize this point. It really is a subepithelial process in many cases. So you see, it's like it's pushing the lumen toward the middle. I'm going to come back to why I want to make that point. It's not something that fills up the lumen and then you destroy the epithelium. It kind of comes from underneath, and the epithelium sort of becomes attenuated. And the epithelium ought to sit pretty much right on top of the smooth muscle. in an airway, there's a little bit of wispy submucosa in there. All this tissue is extra. And so it's like atherosclerosis in a way of an airway. You see this progressive luminal decrease. And that same process goes on in large airways as well. You know, in these patients, it's probably only becomes functionally important in a smaller diameter. So, you know, if you put a millimeter of extra tissue in a small airway, it's going to almost occlude the lumen. If you do that in a large airway, it changes the diameter by a tiny amount, and it doesn't really make that much change. So, you know, really, but that same process probably goes on. Some of these are a little bit less, you know, can be a little less concentric. You can see this pushing up here, but there's, you know, inflammation under here, and eventually the epithelium is going to, you know, may slough off or be lost completely. So I want to show this again, just to remind people that there seems to be some involvement in later development of this lesion in patients who have this preservation injury. Dan Kreisel, who's a thoracic surgeon at Washington University, have done a bunch of looked at this is where the rats were harmed or mice were harmed in the making of this talk. Dan is a marvelous human transplant surgeon, and he's got an army of people who are doing rodent lung transplants as well, which is some really delicate surgery. But this is a really interesting observation that these guys made, because, you know, if you want to say to yourself, you know, well, you know, why does it matter if you have a little diffuse alveolar damage or something early on? What really happens? It turns out that there is some sort of priming. They did these vital dye studies, and you use this sort of elaborate computerized intravital microscopy. And these green dots are actually neutrophils. You can see those lighter blue dots are dendritic cells, and they're actually, the dendritic cells are probably from the host. These are from the donor, and then you've got host neutrophils there. And it turns out that you know, they're when these come flooding in here in the setting of this acute lung injury, you actually have some communication between these guys. This neutrophilic thing is driven by GCSF in these patients, and you see increasing levels of that with increasing times of cold ischemia. It turns out that it's that neutrophil response that seems to mediate this preservation injury. Also is stimulating those graft dendritic cells. And if you blunt that granulopoietic reaction through anti-GCFF or some other mechanisms, you see that you don't get this big spike in IL-12. It also blunts this influx of CD4 and CD8 cells into the graft. And you actually see at least markedly attenuated acute rejection in these mice at you know, early times. And I guess so the large question is, you know, is it this sort of mechanism that, you know, might explain some relationship to BOS? And I'd say, you know, that's pretty speculative. What else have people looked at in terms of links to who gets this late airway process? Lots of people have looked at acute rejection in this, and one of the more recent studies was in the American Journal of Transplant, and these guys looked not only at Duke, looked not only at levels of rejection, but really said, okay, it's going to be a significant acute rejection, which we'll define as someone who has changes in spirometry, rather than, again, maybe one of these occult ones even. And so there's a good link between these, and then, you know, look over time. These patients have an increased hazard risk for the development of BOS. Well, that's not really a new observation. Ever since that lesion was first described, people have been going back and then kind of retrospectively saying, well, okay, what was this patient's course like? Can we see anything? Well, okay, you can correlate the development of BOS with the number of acute rejection episodes, the severity of acute rejection, again, the number and severity of how much airway inflammation you have, which kind of makes sense if it's an airway inflammatory damaging process. Again, that's those B lesions. Lots of people have said, well, you know, infection may play some role as kind of a cofactor or some priming event. So you can see people that have CMV or airway fungus or adenovirus infections, all of which are incredibly common in these patients and make it a little hard to sort out whether it's meaningful or not. Actually, you know, have an increased association with that. There's other things that happen to that airway. they're now completely denervated after they're transplanted. And so, does that somehow drive some changes in its stroma and development of these fibrous lesions? Those airways are also ischemic. There was, if Hannah's sitting back there, she'll remember this odd little guy who came with Dr. Cooper to think about anastomosing the bronchial arteries as a way of preventing this anastomosis breakdown. But there's no direct connection to the bronchial arteries are not reattached, and so parts of those airways, clearly could have some kind of ischemic changes as well. People have said that D lesion that no one ever talks about. In a large session one time, someone said D stands for I don't ever make that diagnosis. But obviously, one might think that again, chronic vascular changes could have some effect on the airways. The types of donor, whether they're brain dead, sort of living harvested donors versus these cadaveric donors. And interestingly, there also seems to be some alteration of the incidence of this depending on whether you get a single or a double lung transplant. Turns out that there's a lower incidence with double lung transplants, and obviously it's also one of the reasons why at least Washington University does almost all double lungs now. If you're really hungry to transplant a lot of people, you can do single lungs on 2 people instead of a double on 1. And if you think about it, if you start to lose graft function and you have only 1 lung, you're going to run out twice as fast. But beyond that just sort of inherent thing of like, well, I have half of 1 lung left as opposed to half of 2. There is some difference, it seems, in whether that's because that lung is getting more blood flow or alterations related to still having an abnormal lung on the other side. I don't know. It doesn't necessarily make sense. Just to dig back in the archives, like a million years ago, we actually looked at a couple of things in some of these early cases of BOS that we could dig up in Washington University. It turns out that while HLA-DR is really highly expressed when you look at acute rejection, there's no real change from control lesions in these chronic rejection patients. The other thing that I think is really interesting is that while of course acute rejection is largely a T-cell driven process, when you look at these patients with chronic rejection, they have a lot of B cells in there. So there's always been this question as are these some low affinity antibodies? Is it a B cell driven process? I think there's still some significant questions about that. But these patients who develop this chronic airway rejection have a much different looking inflammatory cell population there than the patients with acute rejection. There's no question about that. So there's something inherently different about that. And if you go back to all of these things, it's easy to say, well, you can link it to the number of acute rejection episodes. Does that mean the acute rejection caused it? Or does it mean that you're simply a bad mismatch and you're going to have acute rejection, so you're going to get chronic rejection, you're going to have a bunch of other problems? I think that's a question that you can't really answer in these kind of retrospective analysis kind of studies. And because any one of those could really be epiphenomenon that have nothing to do with anything really. Because even in the lungs are not very well matched in many instances. They really only match for blood type and mainly for size of the donors. Many of these patients have, especially the patients with chronic airway disease or chronic fibrosing disease, have a little shrunken up chest, and sometimes it's very difficult to get lungs in there and not have to keep going back and whittling away more and more lung. So they don't do really a lot of complicated matching of lungs as they do with kidneys now, where they have the ability to perfuse them and sort of keep the transplants over an extended period of time and think a lot about who gets those organs. It's sort of we got something and you get it if you're the right blood type and about the right size. The only model that's really out there is this idea of taking tracheal allografts and then putting them in various places in recipient animals, which is, sounds like, well, I don't know, maybe that could mimic a chronic airway rejection process. so people, in terms of this, so you say, well, there's some graft-dependent things. You've got independent things like, brain death or ischemia, reperfusion. You damage that epithelium, and over time, it's inflammation that's going to produce, macrophage and T and B cell infiltrates, and then release, mediators that stimulate this subepithelial myofibroblastic proliferation. Now that sounds great. So, what happens if you take a chunk of trachea and stick it under the skin in a pouch in the mouse? If you come back and look at that in a couple of months, you can see the lumen has been obliterated. Except the problem with this model is this looks like granulation tissue. It's a plug that, the same way here. It's like a plug of something in the airway that's filled the lumen. It's not that subepithelial thing. So they see the same thing when they actually say, well, instead of sticking in the skin, we'll stick this tracheal thing down in the lung, and it'll more mimic a lung transplant situation. The only one of these models that actually looks anything like, I think, the clinical BOS lesions look like are when you actually do an actual transplant. And you take you anastomose the vessels and the airways and whatever, and let it sit there. Now these guys show lesions like this, which I think looks something like that, like those sort of progressive circumferential scarring, and not a plug of something in the lumen. So if you go back and look at these, I think a lot of people look at that and say, that looks like granulation tissue because you took an airway with no vessels on it and stuck it somewhere, and the epithelium dies and you get granulation tissue. That's a much different process, I think, than anything that really mimics what's going on in the donors. And frankly, so there's been a million papers published, and in journals like the American Journal of Pathology, whatever, and they measure cytokines, and I don't believe any of that, because I don't think that's the situation. That model doesn't look right to me, and I think you're measuring granulation tissue and production of fibrosis that has virtually nothing to do with this. And even in the, I've looked at I don't know, 20,000 mice. I don't know. I've never, even when they let them go a long time in the transplant situations I've seen, I haven't really seen this lesion, but it makes sense that if it comes 3, 4, or 5 years later and you have a mouse transplant for 30 or 60 days, are you really going to see that lesion or not? And no one has a really kind of long-term, really long-term model that maybe is going to mimic what's really going on. So I would say that we really don't have a viable animal model for obliterative bronchiolitis. I'm sure some of the people who do these things would argue with me, but to me it looks like granulation tissue. I think a lot of people have that impression, and that any of the data that comes out of that I don't think really reflects very well to humans. And I'd say that the pathogenesis of this in clinical patients, I think, then is still pretty poorly understood, despite the fact that it seems like it's the #1 issue, and but no one's really been able to get a great handle on it. And I wanted to show this 2007 category because there's one thing that's just not mentioned in there at all. What is that? Yeah, there's absolutely nothing. So you're 3 transplant schemes into this thing, and there's no mention of humoral rejection. And they mention it a little bit in the body of the paper, and it's mentioned in 96 too, as like, well, maybe there's humoral rejection, and maybe, it looks like humoral rejection in other organs, but there's no criteria, there's no anything. And so this has been this is still a major drawback. And by the way, obviously, there are, in the kidney or other organs, it appears as though chronic humoral rejection may be really important in developing the chronic rejection. And so, of course, people have said, well, maybe the airway obliterative bronchiolitis lesions are really chronic humoral rejection. It might go back to what we said about there being more B cells there, a million years ago. So we wanted to, so what, as I said, antibody-mediated rejection is really well established in many of the other organ systems, heart, kidney, not so much in liver, again, sorry, Sean. And they have nicely laid out schemes in their rejection schemes to deal with these. Again, we have very little mention of this in that 2007 thing. the classic clinical features of hyperacute rejection, I think, and we may have just had one of these in the heart this week. But these are really preformed donor antibodies. They're going to present with really very early severe graft dysfunction with vascular thrombosis, acute inflammation, neutrophils, necrosis. And no one's going to miss this lesion, obviously. But interestingly, in the lung, it seems as though the cases of AMR that come up later in the post-transplant period can be much more subtle. And you think, well, they must have lesions that are at least somewhat analogous to what you'd see with hyperacute rejection. Would there be a capillary injury? That kind of goes on in other organ systems as well. You see capillaritis in the kidney. There's C4D deposition around capillaries in the heart, in heart allografts. And so you think, well, maybe there's neutrophilia or capillaritis, and how subtle can this be? So we actually, again, the NIH consensus conference definition of AMR would include that you have a demonstration of circulating anti-donor antibodies. And again, the way that those are defined has really changed, kind of dramatically over time. So, I think it's like everybody has them now. It almost seems like, depending on how you, I'm not an HLA or immunologist, but depending on how you measure them and where you set the thresholds, you can really dramatically change whether or not someone has, just by your working definitions. But there should be allograft dysfunction, I think, is kind of one of the major points that's still been made about making that diagnosis, is there should be something wrong with it. So, we would like to think maybe you don't really have significant humoral rejection that's, an occult process. There should be some tissue histopathology findings, and it would help if we could demonstrate some complement deposition. We think that's important. So we actually went back and looked at what we could find in terms of patients who at WashU had been diagnosed with a clinical syndrome of AMR. They had dysfunction, they had anti-donor antibodies, and then just kind of in reverse, rather than saying, well, we pathologically to find out what's their clinical symptoms, kind of went in the reverse mechanism, and then took a look at the index biopsy when that was made to see what it looked like, and did some C4D staining on these patients. So it turns out we could find 18 patients that seem to have this clinical syndrome. The time, as you'd expect, really the time from transplanting these patients, there were a couple of early ones, but most of them were pretty late in the first year. So you think, oh, this is going to happen early, and we're going to see that. But a bunch of these came on much later, and some of them were more than 2 years out. Almost all of them had documented circulating antibodies. Some had just measurable anti-HLA antibodies alone. Others had kind of more standard flow or cross-match positivity on top of that. Some of these only had the anti-HLA antibodies measured. And all of these patients had features of allograft dysfunction. They had infiltrates. They had decreased spirometry. They were symptomatic. And it really appears that the biopsy findings are really quite variable. Of course, the most common finding was just acute interstitial inflammation. We saw neutrophils in the septum. Some of those, that was present in 13 of the 18 cases. The annoying part of this thing, though, is that 11 of the 18 cases really looked like organizing lung injury or bronchiolitis obliterans, organizing pneumonia. Just this kind of standard acute lung injury picture. Well, of course, that has obvious overlap with 8 million things that could happen in those patients, including infection or drug reactions or anything else. And in fact, there's this strong sense that we would see back in the 1990s, you would see patients who kept coming with like stuff that looked like organizing pneumonia, and we'd work them up for infection and then get culture. They had nothing. It's really quite possible that that's what these patients had. And if you look here, the findings with this septal neutrophilia are pretty subtle sometimes. You can see, neutrophils, they really don't belong there. None of them are out in the, it's not a pneumonia, none of them are out in the airspace. But as I said, a lot of these patients really just kind of show organizing pneumonia pattern. And, there's a long differential from that, starting with CMV and ending with, a bunch of other infections. So in many instances, that's the default notion is that, oh, these guys have an infection, and you go looking for virus, and they get cultured. In fact, now many of these patients getting this multiplex viral PCR, they're coming back negative, whatever. So there's a lot of work, work to rule out other things with these patients when they look like that. What you would think, well, it must be the hallmark of an antibody-mediated rejection would be some of these vascular lesions. We could only find those in 8 of those 18 patients. Some of them had this kind of small vessel capillaritis or small vessel vasculitis. When you damage the vessels, obviously you can get some hemorrhage, but that's quite common in these biopsies anyway. Some just very rare patients had anything that looked like some necrosis of the alveolar septae. And of course, some of these patients are going to have acute rejection on top of it. So here's an example really of some capillaritis. You can see a small vessel here with this, looks like it's ringed by neutrophils. There's some more sort of hanging out around these things. And of course, when you damage the vessels, you get this fibrin exudate, and that's where that organizing pneumonia picture is going to show up here. If you biopsy these patients a little bit later, it's going to look like organizing pneumonia, and you may or may not be able to pick up on the fact that there may be this kind of subtle capillaritis in the background. Here's a nice example of that with some neutrophils kind of hanging out here right around the capillaries. And there's some nuclear dust or some little fragments in here as well. But this again is a pretty subtle lesion, and I think could be easily missed. Here's another small vessel with a couple of neutrophils in its wall, and there's a little bit of again some of this interstitial neutrophilia elsewhere. And some of these patients go on to get hemorrhage and some other lung injury in these patients. So relatively convinced that that's what's happening in these patients. There's an example of somebody with some concurrent acute rejection with some lymphocytes around some of those vessels as well.
Did you get some hyaline membranes in that last
Oh, yeah, absolutely. Yeah. And again, it's going to look like many of those, I think the ones that look like diffuse alveolar damage, that's exactly where they're coming from. And at that point, once you have that much lung injury, you ask yourself, well, of course there's neutrophils in the interstitium because that's what made the lung injury. So it's a difficult thing to sort out in many cases. Looking at C4D immunostains in the lung is kind of difficult because there's all this elastic tissue that loves to grab everything in sight in terms of immunostains, especially this one. So we looked at 14 cases. We thought we had positive vascular staining. Now, what should that pattern be? Well, I love it when people tell me this. This is my favorite thing in the world. Everybody says, well, in the kidney, you have to have more than 50% capillary staining, so that's what that's what it is in the lung. I said, that's interesting. Does the lung make urine? No. Is the kidney exposed to external antigens every time you breathe in? No. So the immunology and the function of the lung, I think, is markedly different. So, it's kind of speculative. If you want to say, okay, fine, we'll just sort of try that as a trial definition. Absolutely. So we saw only a couple of our cases could you really say, yeah, we had this sort of diffuse, staining of more than 50% of capillaries. It was more focal in 10 of the 12, with kind of variability from piece to piece. And that doesn't surprise me because the same thing is true of acute rejection. It's got sort of zonal distributions in the lung, and it may be the same for humoral rejection, even though you think, well, it's vascular driven and it must be very much the same in all the pieces. A couple of cases showed only large vessel staining, which would, in other organ systems doesn't mean much. I don't know, absent anything else. I don't know whether that's important or not. Many of the cases, some of these cases also show a lot of fibrin exudate, but this looks like relatively nice capillary staining, I think, and you can see it's many of the capillaries, or most of them, and seems to be endothelial based. I would say this is relatively convincing. You can see again this nice, I think reasonably nice sort of capillary lumen staining. Not a lot of background here. As I said, some of these cases showed mainly, this kind of large vessel staining, and I don't know, it's hard to really know if that means anything. And as I said, when you've got hyaline membranes, there's obviously likely to be complement and other things in there. So you can see, again, this, probably kind of nonspecific staining of that, which, really makes looking at whether there's anything else in the background of those cases, I think, relatively difficult. But just in conclusion, I think AMR is probably important in this setting. I think it's important to remember that it seems that most of the cases occur outside of that early transplant period when you think that's when you ought to see many of them. And really, acute interstitial inflammation or organizing lung injury patterns are really the major things that we're likely to see. And so you have to have in the back of your head, if we're seeing an unexplained case of those, that's something to really start keying in on. And of course, the clinicians, I think, are getting much more attuned to the donor antibody side of this. But if we see unexplained organizing lung injury, I think we ought to think about that. And it'd be great if you said, wow, this small vessel vasculitis is a really distinctive finding, but it's not seen in very many cases in necrosis or hemorrhage or these kind of gross lesions that you would expect to see in somebody that's got a really severe, kind of massive hyperacute rejection. You're not going to see very often. Most cases will have some sort of C4D staining, although whether it's diffuse or focal or not, I think is still to be sorted out what the important patterns are, and whether large vessel staining or anything else is important or not. I think is a matter of speculation. So before I left Washington University, we were helping to set up this HALT trial, which stands for HLA antibodies in lung transplant, and they wanted to say HALT BOS, like, wow, because if you have a good acronym for your trial, it really it helps it. But looking at some of the other major transplant centers, Pennsylvania, Southwestern, Stanford, Cleveland Clinic, and the idea is to take some of these patients and see whether if you have clinical features and biopsy features and it looks like AMR, if you actually treat them with rituximab and some other things, is it actually going to change their outcome? If you follow them long enough, will it change their development eventually of BOS? Again, that's a big question. One of the other goals, though, is just to really get some more knowledge. Because if you look at any one institution, the number of biopsies that you can really use to classify this are not very many. So trying to have a multi-center approach to look at those biopsies. And I would have loved to have stuck around to look at these. And again, there's other controversies. Is IHC appropriate to do that? Do you need to do IF on lung biopsies? I'd like to say that IHC was okay for that, but if you look at kidneys, I think most people would say IF for those things is better than it is trying to do it by IHC. And especially given the problems with elastic staining and some other junk in the lungs when you do amplified staining techniques, it may be that IF is better. And so part of that trial was really to compare IF findings and IHC and see whether C4 or C3 was better or some other related questions. So we've come mostly to the end of this talk. I'd like to say that I think the lesions of acute rejection and the management of those, whatever, has been relatively well understood. I think we've demonstrated it's reliable. I think people have had a handle on that for a number of years and is much less of a problem. I think there's still a lot to do in terms of chronic rejection. As I said, it's the number one problem, and everyone acknowledges that that's the number one issue that's sort of life-limiting for a huge number of these patients. And as you fix all those early problems, you keep from giving the patients PTLD, and you manage their rejections, and you don't give them a lot of infections because they're over immunosuppressed, and you do all that other stuff only to get out a couple years and see BOS come along. It's disappointing for everybody. And so I think AMR is likewise relatively poorly defined at this point, but I think it's probably a very important lesion in these things, in these patients who will have a significant rate of this developing, and hopefully over time our understanding of what the criteria should be for that, what the diagnostic features are, and again taking that to the clinic and saying, will interventions change that? And my final point would be that sometimes painful resident interactions can lead to something fruitful later in life. So I think that's important for all of our residents to keep in mind. That annoying clinician might turn out to be somebody that you work with over the next 20 years. Oh, thank you. Any questions or comments? Yes.
John, that was fascinating talk. Thank you very much. I have a comment and a question. Number one, early in my career, I had the opportunity to work with experimental lung transplantation, and we actually tried to do immunofluorescence on those, and this was actually before immunobroxidase was even around. And I found immunofluorescence on the lung very difficult to interpret.
It's the same issue because of the autofluorescence.
Right, there's a tremendous amount of autofluorescence, so it's very difficult to interpret.
Mm-hmm.
The question I have is, it seems to me that if you have humoral rejection involving the interstitial capillaries, the capillaritis with C4D deposition, that this conceivably could be the process that leads to bronchiolitis obliterans. Don't you think so?
I do. You know, it's interesting that yeah, and it's, I mean, you're absolutely correct. You see really a similar process, I think, in the kidney. You know, you have vascular lesions, and you wind up with glomerulopathy or other lesions of even if that's not seemingly the direct area that you're looking at, and certainly there, you know, it's the presence of circulating anti-donor antibodies and other things is another thing that you can put on that list of things that correlate with development of BOS later on. You know, and again, it may go back simply, you know, maybe that's again, you're back simply to the fact you're a bad match and you're going to have anti-donor antibodies as well. But I think I think that's and obviously that trial that I mentioned, you know, they're doing a sort of preliminary trial to look at that, but they would love to then take that into a long-term trial and say, you know, if we identify patients who have AMR or various components of that, manage them aggressively in terms of their treatment, is it going to change the rate of BOS later on? And, you know, that's a long-term project, but I think that's a really key central question. Yes?
John, I've seen what was clinically called BOOP in some bone marrow transplant patients on ventilators, respiratory decompensation. A few of them had biopsies and were called BOOP. Number one, do you acknowledge that this is seen in those types of patients?
Oh, absolutely. So if
you think is the common pathway, the same process?
Oh, absolutely. If you take actually, well, they may have had BOOP, but they may have had obliterative bronchiolitis or BO, which, you know, it's one of the reasons why people want to get away from the term BOOP because it gets confused with. But any of the lesions that I described in terms of lung transplant, you see in bone marrow transplant patients. It's just in reverse. So graft versus host looks exactly like that. And I mean, you know, of course, you know, we have 1 million transplant patients here. I've seen at least, I think, 3 or 4 cases of obliterative bronchiolitis as kind of a late manifestation of GVH since I've been here. So it's common. You see those. You can see those same kind of paravascular infiltrates. You get lymphocytic bronchiolitis. It's the exact process, just with the roles reversed. Thank you.